We're going to start off with the panelists just doing a brief presentation of the innovations that they are working with. And I just wanted to kind of point out that this is very timely for us because, as some of you may be contributors to the Classic Cause, and this year the Classic Cause for Billings Clinic is psychiatric services. And we're involved in a lot of different things, being the only psychiatric inpatient facility in eastern Montana. We do a lot of things in mental health, and we work with many partners in the community. But these folks are really on the cutting edge of trying to find ways to help those folks with mental illness lead lives that aren't as disrupted by that mental illness. And so I'll stop talking and let them, as the experts, tell you about the exciting things that they're doing. And we'll start with Dr. Walter.
Hello, I'm Liz Walter. I've been in the Billings community for about 15 years, a little over now. I'm a general adult psychiatrist. I've worked in various settings here in Billings, including the inpatient unit here at Billings Clinic. I've worked in outpatient. I've provided ECT treatments for patients. I do a lot of medication therapies, and I do some psychotherapy. What really has struck me over the last 20 years of my education as a psychiatrist is how much our treatments have advanced, but despite our best advancements, there's still a lot of room for improvement in what we do and trying to help people get better. And that's our major goal. It takes a lot of effort, both in trying to treat people's mental illness, to try to make sure that they have good physical health care so that they can have good mental health care, and vice versa. And so over the years of me seeing how people have responded to treatments and care, it became very apparent that our treatments, even the best ones that people get, which are very available here in the community, were still lacking to get people completely well. So I have been interested in horses my whole life, and I had somebody mention to me that they had heard about using horses to help people with mental health issues. And I initially heard that, and I was fairly skeptical about what that application might be, because I thought, well, I'm not really sure if that's appropriate or not. And then I looked into it, and I started doing some of the trainings, and I was fascinated to find out how good horses can be at helping people. They can be very good at helping people identify some of their own struggles, and they can be very good messengers for people about where the struggles are and trying to help them understand what that is. It takes people out of a typical office-based setting, and it gives them the opportunity to interact in a very innovative, very creative, and a very unique situation where I can learn a lot more about them than I feel like I ever learned in my office. What we're trying to do now is combine medication therapy during these equine-assisted psychotherapy times that we have in the arena. And we've been finding some very interesting things, and I think it's been very interesting and I think very helpful. Of course, not every treatment is helpful for every person, but I certainly think this offers a new treatment avenue for people. And I've been very excited that Billings Clinic would support this and all the other innovations that we're finding with all the other people who are here today to talk about that. So that's really where we've started. Our program is fairly new, but I think so far it's been very exciting and the work has been very interesting. So I'm going to give you to Dr. Herrera right now.
Thank you. Hi, I'm Mariela Herrera. I'm a child and adolescent psychiatrist working in the inpatient unit here in Billings Clinic. And I've been here for less than a year, so I'm a recent graduate. I'm going to talk along with Diane about depression, and we're going to talk about another innovative treatment that we have that's called triple chronotherapy. And we'll explain a little bit of what it is about, and maybe, talk about and answer your questions related to this treatment. So as a child psychiatrist and especially working in the inpatient unit, but also happens in other settings, we see a lot of kids who struggle with depression. And this is a disease that starts usually in the teenage years, but can start even earlier than that. And depression is not only feeling sad. So we all have felt sad. We all have had periods of, low mood. But there are certain criteria that are included when we talk about depression. So depression is not only affecting mood, but it's a disorder that affects other features of functioning, such as concentration, attention, sleep, appetite, motivation, interest in doing things, ability to enjoy. When it's very severe, it can be associated with suicidal thoughts, can be associated with psychotic symptoms, and it can actually impair functioning. In teenagers, it can lead to development of comorbid conditions like substance use disorder or behavioral problems. So, and it's pretty prevalent in teenagers. We can see it in 4 to 8% of kids. So that's one of the most prevalent conditions at this age in terms of mental health. So our current treatments for depression include psychotherapy, medications. So the American Academy of Child and Adolescent Psychiatrists recommends a combination of medications and psychotherapy. Our problem with these medications, with these therapies, we don't have a problem with it, but it takes a long time for them to start working. And many times the level of depression and the acuity of the suicidal thoughts is such that we would like to have something that works faster in terms of helping these kids with these struggles. So that's when more new therapies come in place. In adults, of course, ECT is an option. It's been tried in teenagers, but it's more invasive. So it's something that's called electroconvulsive therapy. For those who don't know, it's a kind of treatment that requires anesthesia and can lead to very good results, but is very invasive and has its own risks. Some people are studying ketamine infusions, so infusing ketamine IV, so through the vein, to get faster results for depression. But that's also involving certain medications that can be dangerous. So there's a treatment called, the treatment of triple chronotherapy has been studied in adults, and it has shown good results to lead to a faster relief or decrease in the depressive symptoms. And that's what we're doing in the unit. We're trying to get a research study going on about, is this effective for kids as well? And what are the side effects? Is it safe? And so far we've had many kids doing this therapy outside of the research study, and it's shown good results. As Dr. Walters said, not everybody responds to the same things. So, some kids do better than others, but it looks promising for now. And I'll let Diane explain a little bit more of what the procedure entails. It's been also an opportunity for collaborating between physicians, nurses, opening the door for research. Billings Clinic is a great institution, and we get a lot of patients from around not only the community, but different places. And I think if we can not only help these kids, but also contribute to science in a place like this, where we see all this acuity of patients, it's going to benefit not only other patients, but also the community and our institution. So I think that's another part of this that's very important. So I'll let Diane explain a little bit more about what the therapy is, and then we'll take your questions later. Thank you.
I'm Diane Heard. I'm a charge nurse here at Billings Clinic in Psych and primarily on the youth unit. Before that, I worked for 6 years in Rapid City on a youth unit as well. Well, I want to stress that our use of triple chronotherapy really started with a patient, a very difficult patient that we kind of ran into a wall, very severely depressed patient, self-harm behaviors, just covered in cuts, self-inflicted cuts. This kid refused to take any medication, and we really didn't know, where to go with it. And so our physician was aware that there was some use of triple chronotherapy in the adult population and that it was an adjunct, or it could be used, if you didn't use any pharmacology. So read a little bit about that and decided we'd go ahead and give it a try on this kid because we didn't have anything to lose and he agreed to try it. And so we did that, and the results were absolutely amazing. This kid went from we used instruments, the Hamilton D. He was in the mid-20s, which is like severe depression. And by the time he was done with the 5-day protocol, he was starting to score close to 0. And by the time he actually left, there was no clinical signs of depression. He had stopped cutting. We were very blessed to have like an amazing, first case. But we wanted to do more. We wanted to see more because it had been so successful. And so we've trialed, I would say outside of the study, maybe about 10 patients, and I would say probably about 2/3 of those we saw really successful results. So, we've been very excited about it. We've gotten a lot of support from the clinic and been able to come share about the things that were going on. So let me tell you a little bit about what this procedure is like on the floor, because it is a 5-day protocol, and you see this dramatic drop, but it entails triple chronotherapy, so there's 3 interventions. One is sleep deprivation, which is the first 36 hours of this protocol, the patient doesn't sleep. So we have a 1-to-1 assigned to the patient. They play cards, they play basketball, whatever it takes to keep that person up for the first 36 hours. Then we go into a sleep phase advancement where we advance the sleep and the bedtime shifts for the next couple of nights. And then every day throughout the protocol, we do light therapy in the morning for a half an hour. And this is kind of a reset of the circadian rhythms. And like I said, you just see the scores drop. It's really an interesting thing to see. So it had been shown to be successful in adults, but there had been absolutely nothing done in the adolescent population. And so I don't think originally we thought we're going to end up being researchers, but it was just too intriguing that there really had been nothing done in adolescence. And before you know it, we were writing an IRB proposal and trying to get approval. And so that's what we're doing now. We're doing an open label pilot study, which is kind of where you kind of decide, is this feasible in this population? And we're probably about 5 or 6 subjects into it. And so now we're, these are all frontline nurses trying to, and physicians and whatever, we're trying to figure out how to do research on the floor. So it's really kind of exciting that we're doing this, right on the floor where the patients are in the hospital and so forth. So, that's, as we follow through on that, then we'll see kind of more what the results are, what things we can anticipate, what things we need to change, et cetera. We'd love to be able to go forward with maybe some, randomized control studies and that kind of thing. But it's very exciting that physicians and nurses can collaborate and actually be contributing to science in this area. So, thanks.
So I'm Christine Tobin. I'm a licensed clinical social worker on the inpatient youth unit for about the last 3 years here. And we started looking at trauma-informed care about 1.5 years, 2 years ago. And Diane has been involved, and Dr. Herrera, of course, and Dr. Zubi and other people on our unit. But really, it started with an ACE talk, Adverse Childhood Experiences study that was done. And I know for me, that's what really started my passion in this, exploring it, looking for it, because it really made sense. It looked at how poor outcomes for health impact, lost my train of thought there, impact, mental health, your health, how people do. And that's the people we see. It's like, why isn't treatment working? Why do we keep seeing the same patients over and over again, and why aren't they getting any better? But then you can kind of look at this ACE study that, they've experienced this chronic toxic stress most of their life, and it makes sense that they're not doing well. And if you look beyond kind of like the surface behaviors that most people present with, you can kind of get a little deeper. And so we started looking at this, like, what can we do on our unit? How can we improve patient outcomes? How can we prevent burnout of staff, reduce seclusions and restraints on our unit? And we came up with trauma-informed care, which is not really a modality like equine therapy or triple chronotherapy. It's more of approach, how you approach a patient. It's a lens through which you kind of look through and see that this is, how do you see our patients differently from what's wrong with you to how can I help you? What has happened to you? And so we do that by our language, our interactions with our patients. It's kind of just a full approach of that. And then what else?
We're rolling out a curriculum on our youth
Yeah.
unit right now that's totally trauma-informed care.
Yep, we started doing that. We are trying to implement we're implementing a curriculum called attachment regulation and competency, which our kids will participate in, and they'll learn the skills to self-regulate. And eventually, hopefully, not be able to have to, repeat visits, and they'll feel better and not have to come see us. I feel like I kind of over-prepared, so all my stuff's like,
If you have some questions, please go ahead and write them down and pass them to the aisles. Leslie will come around. I do have a couple questions I wanted to kind of throw out to start with here while you all are doing that. I guess the first one will go to Christine. Do people have to be hospitalized for trauma-informed care to be effective?
definitely not. It's, like I said, it's an approach. So it's how you interact with the person sitting next to you. It's how you interact with anybody. It's where have you been through? I mean, you don't just start attacking somebody if they're having a bad day. You go, what's wrong? What's happening? What can I do for you? So you don't have to be hospitalized to have a kind approach.
And just to, if I can add on that, I think part of the approach involves teaching and educating the family and the communities, the schools about this approach, because we can only do so much in the inpatient unit. We're not a long-term placement. We're a short-term acute inpatient unit. So it's really something we can do in the unit for a few days, but if they go to the same circumstances and there's no education with the families and the community, we go back to the same. So it's very good to do in the hospital, but we need to also move on to educating the community and the families about this.
Well, while we're sorting, is there research, Dr. Walter, is there research to support equine-assisted psychotherapy?
There is research, but it's mainly in its infancy at this point. And I think one of the really nice things, as you've heard from the other panelists here, is how interesting it is to be able to do research. And I think that's one of our hopes, is that we'll be able to gain competency in in equine-assisted psychotherapy and that modality, and hope to advance, as they have, to really looking at it in a more formal fashion. This September, we're going to have Dr. Manette Monroe from the School of Medicine at the University of Central Florida come to do a grand rounds on her work with using equine or horses in medicine. And so I think there is data. Most of this is not in the form of the data that we might see looking at different medication trials, but there is data to support this use, but we're looking towards trying to advance that data and looking how it might be specifically helpful. So we're starting here just to try to learn what this treatment modality is like and how we can maybe formally participate in some of the research trials to see how this can be delivered in the most specific fashion in the future.
All right. So I've got several triple chronotherapy questions that have come in. And I guess I'm going to combine a couple of these. There's a question about the treatment of bipolar depression. And I guess that's kind of for all four of you. Are these innovative treatments that you're working, is bipolar something that you can affect with the different modalities that we're talking about? And then the other one is the interaction of medication with both triple chronotherapy, equine therapy, and also in trauma-informed care. Are they standalone kind of treatments, or are there other things that we do at the same time?
So in terms of bipolar disorder, and for those of you who are not familiar with bipolar disorder, so we have unipolar depression is what I described first. So that constellation of symptoms, people get into these episodes of depression. When you have other patients that not only go to episodes of depression, but this is your normal, or usually your mood oscillates in a normal range. But some people get too high in their mood. So they have periods of 5 or 7 days where they're not able to sleep, it's more like they don't need to sleep. They can go 2 hours a night without sleeping more than that, and they get a lot of, even with that, they have a lot of energy, they're super happy, all over the top, thinking grandiose, like I'm a millionaire, I'm gonna be a rock star, and they spend a lot of money that they don't have. They just get into risky behaviors. You know, people notice that they're different, talking a lot, very energetic. And that's what we call bipolar disorder, when you have both poles of mood problems. Triple chronotherapy has been used for the depressive phase of bipolar disorder. Since it's a treatment that's aimed at treating depression, every person who has bipolar disorder can get into these depressive episodes, and they usually spend more time in depressive episodes than manic episodes. But any treatment for depression in the setting of bipolar disorder can trigger a manic episode. So we do use it, we're just more careful. And moving on a little bit to the second question, we do this treatment as an adjunct. So this is not a treatment that we do only. This treatment, we do it with the combination of usual care. So along with medications, along with the therapy we do in the unit, we combine or add this treatment to see if we can get better and faster results than what you can get with the medication and therapy. So for bipolar disorder, when they're in the depressive state, if we use this treatment, we usually want to combine with something that would prevent that jumping to mania phase, so like a mood stabilizer on top of this depression treatment, if that makes sense.
Trauma-informed care or equine therapy in bipolar, is it something that you can speak to?
Sure. Equine-assisted psychotherapy isn't necessarily specific to a particular phase, as Dr. Herrera was referring to, of bipolar disorder. It can be used to be beneficial in helping people understand what their mood symptoms may be like over time. It can be used to help treat things like understanding people's isolation when they're depressed, or understanding how people may cope or act differently during their depressive episodes. It's probably not something that's, like Dr. Herrera was mentioning, this is not something that I would use independently to treat bipolar disorder. That's why we're combining it with medications, because we think that medications and good quality psychotherapy are some of the most standard and researched ways to try to help mood illnesses. What we're seeing, though, and what we're trying to do with the equine-assisted psychotherapy is allow people to come to a different place, maybe not the typical office-based setting. In that, they are able to look at some of their own behaviors, and the horses can be very good at reflecting what's happening in people's lives. And the horses and their activities that we're using can be very helpful at helping people understand why they may act certain ways. How do they cope with adversity? What are they doing? And one of the things that I like about this treatment modality is that it's good at allowing people to figure out their own solution. So when we're working with the horses, a lot of times what comes up is people will see what's happening in their day-to-day lives and say, I don't think I would like it if I didn't do that, or maybe I should be doing something different. And what that then points out to them is, well, how can I do that differently? And maybe in that moment of understanding, they then start changing some of their behaviors. And so we're still using medications. I'm still using medications in the treatment for that, because I think we need all of our treatment modalities to get people better. So it's not specific to a phase of the illness. It's really helping people, to try to help people understand how they manage their life, what skills they have, what can they do in their own life to help manage their symptoms better. So that's really where we are with that.
The question is, can she give an example?
Yeah. Can we do this? Can I, in order to think of a really good example, I might need a second or two to think on my feet. Maybe you can ask another question and I can come back to that? Yeah.
A person with bipolar could have trauma, an experience of trauma or not, but for instance, the curriculum that we're using is called the ARC curriculum, and it is a trauma-informed care framework. And the building blocks of ARC are attachment, regulation, and competency. So those building blocks work very nicely with someone with a mood disorder in terms of learning to regulate, or attachment and relationships. I think we can use that, very, very well. And I think they're probably, the general population usually, there's a high number of people who do have like an ACE score or a trauma in their past. So I think it works very nicely with people, whether they're bipolar or not bipolar.
Okay, to follow up on that, Diane, one of the questions was, as a family member of someone with a bipolar disorder, the person with the disorder doesn't like how they feel on medicine. Would the ARC program and trauma-informed care help them to understand their need for medication, or how they might someday get off of the medication, or is there something in that?
I think as people become self-aware, because I think self-awareness is a lot about what this whole curriculum is, based on. And if you become more self-aware, you're going to kind of realize that you're doing better with the medications, and you're going to learn some skills that would assist you to do better. And I think medication adjustments will be easier. So if you're working with a provider, I still think the trauma-informed care is a wonderful adjunct.
But I do want to emphasize that the trauma-informed care is a treatment that's developed for post-traumatic stress disorder or complex trauma. So many of the features of this treatment can be helpful for mood disorders, anxiety disorders, but this is not what it is designed for. So we do see a lot of kids and adults in our units that have been unfortunately exposed to a lot of traumatic experiences, abuse, abandonments, or any, there's a lot of bad things that happen, unfortunately, to the kids and teenagers. And the way this affects the brain is a little bit different than the way, mood disorder or anxiety disorder tend to work on the brain. So it is designed to this population, not that it can't. It's going to harm other populations, and it can actually add more skills for other populations. But when we talk about trauma-informed care, we're talking more about how to deal with the effects of trauma, and how we can teach not only the kids, but the staff as well, on how to manage these symptoms that come from trauma. So,
Dr. Walter, have you?
I made you give me a little more time than that. One of the things that comes up, I think, a lot for people who have mood disorders or even anxiety disorders is what happens when they don't feel well, and what happens to their relationships with other people. Oftentimes, they'll find that if they're not feeling well, they tend to be more isolative, or perhaps they tend to be less assertive. And sometimes, though, over time, if you have chronic illnesses, sometimes your way of interacting with the world and seeing the world becomes fairly inflexible or fixed. And what the horses, I think, have been very good at doing for people is helping them see, how do I see the world? How do I see myself? Am I somebody who's going to retreat from an interaction? Am I somebody who's going to be more assertive in that interaction? And so I think one of the things that's happening is we're starting to see where people are starting to see some of their patterns at interacting with the horses. The horses can be very good at, say you have somebody who may be a little bit more meek, or who doesn't have really good self-esteem, or somebody who's less assertive. You see the horses tending to encroach towards that person. They push, they push, they push. And you watch those people back up and back up and back up and retreat. And over time, what you can do is you can talk to people and you can say, I notice that in your interactions here, you keep moving backwards from the horse. And you can kind of just let that sit for people, and sometimes people will go, yeah, that's true. I do that in other areas of my life. And they think, I may need to think about that. And the nice part about that is I really didn't have to say much. All I had to say is I've noticed this, which is true. I've also seen it work the other way, where people maybe can be very assertive and the horses don't want to stick around. They're somewhere else. And so it's very interesting to talk about what's happening in the arena, and people will see, just without a lot of prompting, how that might affect their lives. And I think that's the very nice part, is it's a different way of seeing their behavior through interaction with an animal. And so I think that's been really fantastic, because it's sometimes easier to hear the message, maybe not from me or somebody in a white coat, but it's easier to see what's happening by your interactions with an animal. And so I think that's been very powerful.
Kind of grouped some of these. How do you identify someone who may benefit from triple chronotherapy?
Well, for the current study, we have guidelines. We're looking for someone who is, 13 to under 18. We're looking for moderate to severe depression. I think our exclusions are that we don't want to have anyone who's in a mixed or manic state. That's not a safe person to use in the unit. I think that's the only. Can you think of any other?
So we are including patients who have acute suicidality, and other than what Diane mentioned, that's what we're looking for. So the studies that have been done in triple chronotherapy are addressing this population, and that's why we are considering this population. So as she said, major depressive disorder with moderate or severe symptoms. This is not a treatment. It can be unipolar or bipolar depression. This is not something that we recommend to do at home, because it's not something that we have tried enough, and you need to have certain staff with the patient and be sure that you can handle a situation if it comes. So we do it for kids who actually need to be in the hospital. So in other words, we're not necessarily hospitalizing for this treatment, but the kids are meeting criteria to be in the hospital. So the safety concern is high enough that we are thinking the kid needs to be in the hospital. So hospitalized kids with depression, mild to moderate, suicidal ideation, 13 to 18 years old. We can definitely consider in other populations, so older people or younger people, but we work in a separate unit than the adult unit, so that would require some coordination with the adult psychiatrists.
I was going to ask, wouldn't you say we use it a lot for people who have sleep problems? Like, that's usually like an indicator that we've seen with the people that have done it. They don't sleep.
Yeah. And it goes along with the constellation of symptoms of depression. So that wouldn't be something that's required, but most of the people who have depression will also have sleep problems. So that usually goes hand to hand, and we many times see that the sleep schedule improves. And we're starting to do more follow-ups of these patients to see how long the effect is lasting for, because of course we want something fast, but we want something that's going to stay. So we will have more results when the first follow-ups come to see if the sleep schedule continues to be positive, if they remain in that schedule, and if the antidepressive effects continue to last.
One of the other criteria for a subject or someone that would do chronotherapy is motivation. So we're looking for a motivated patient. And for the study, parents have to sign consent, but the teenager signs an assent too. And you have to have someone who's willing to do this. And so that we are screening for that too. We've had kids say, oh, no, I would never want to comply to that schedule. I'd like to stay up all night. So we don't then, no, that person doesn't, even if they met other criteria as well. And as she was mentioning, the sleep, we are doing the instruments that we do on a daily basis. We are looking at how they're sleeping. We're looking at their anxiety levels. We're looking at urges to self-harm, the non-suicidal self-injury. Some of these things are what we're looking at also, in addition to what's going on with the depression and the suicidality.
So Christine, the question for the trauma-informed care piece, lot of people in Montana are outside of the urban areas. Is trauma-informed care something that we have plans to try and train others in the community, get out and help others to kind of have some resources in dealing with people in a different way?
I'd say definitely. I mean, we have the distress grant that's a collaboration with Riverstone, St. Vincent's, Billings Clinic, and other community partners that are working towards becoming trauma-informed, that's working on the neurosequential model of therapeutics, which is another therapy piece there. And hopefully, with this ARC piece, we've had people come from, I think it was Missoula, someone came and taught us about ARC, and that is our hope, that we're going to spread this around, that there's going to be people talking about trauma-informed care everywhere, from schools to hospitals to daycare settings, everywhere, and just being more aware, even if it's even a dentist's office. You see better outcomes, and people feel better, they feel more empowered to come back, and so that would be our goal.
Dr. Walter, how do you identify somebody who could benefit from the equine therapy? And is there kind of a length of the treatment that seems to be optimal?
At this point in time, the way we're identifying people is mainly by people contacting us and saying that they're interested. There are very few what I would consider to be exclusion criteria for people who wouldn't benefit. Usually what's happening now is I meet with everybody in office before I have our first session at the arena, just to make sure that treatment goals that they have would be consistent with things that we think that we could help them with. It's a non-riding program. I don't know if that's something that everybody understands. So for instance, if people wanted to come and ride a horse, that's not what equine-assisted psychotherapy is about. So that's one of the things to make sure that people understand. Can you tell me what the second part of that was?
Is there a length of the intervention that seems to be?
Sure. Equine-assisted psychotherapy is typically what's considered a short-term therapy, and that's probably somewhere between 8 to 12 weeks. Now, that said, I think that there's going to be people who feel like they can come and they may spend 3 sessions and say, I got what I needed from this. It's helped, and I feel comfortable. Or there's somebody who may say, look, I'm going to do it for 3 months, and that's enough. Or there might be people who say, look, I think I need it to be a little bit longer, and maybe we'll have to do it, maybe we'll do it twice a month for 6 months as opposed to 3 months. So I think we have to be very flexible, and what we're trying to do is to make sure that people feel that there's some measure of flexibility. I think as a new program, you have to figure out what works for everybody, no different than you find out when people come back to your office how long they're going to continue to see you and if they're well. That really is the goal of this, is to find a way to help people feel well, because I think what I've seen too is that sometimes we get medications and people get better, but they're not well. And this is really a hope in that people start to feel like they get not all the way, they're not just well, they're better, and they feel like they can live the lives that they want to have. And I think that's what all of us are saying, is that we really want to find a way to get people better. And I think we're having to look towards other new applications to really find that.
And one other question, why horses and not some other animal?
Because I'm afraid of snakes. Yeah. There's a lot of people who say, why not a dog? I really like my dog. And those of you who are dog lovers, I'm not trying to insult you, but most of you, if you've been around a horse, know that if a horse doesn't like you, they're going to leave. And dogs tend to stick around, even under sometimes stressful circumstances. So the one thing that makes horses pretty unique is that they're prey animals. So they're highly attuned to their environment because, as you know, if they're not paying attention to what's around them, they potentially are lunch. And so that makes them very good at being attuned to people's body posture, nonverbal communication. And so they're very good at picking up on that. And they can reflect what people are showing them in ways that sometimes can be very vexing to people. But also very therapeutic. And so that's why horses.
There's a couple of questions in here about light therapy has been out there for seasonal affective disorder. How is triple chronotherapy different than than the treatment for seasonal affective disorder, and are there parallels?
I guess it's different because we're not treating the same condition, of course, and we're combining it with the sleep schedule modification. On the other side, the lamp is the same that would be used in seasonal affective disorder. Is a 10,000 lux light therapy lamp. So what we know about sleep is that we have a circadian rhythm in our bodies. So we, just like with the gut, you know when you're hungry, you know when you're full, we know when you have to go to the bathroom. It's usually the same every day, right? For the sleep, the goal with what's healthy is that we have a sleep cycle as well. So we go to bed at the same time, and we get up at the same time, and we have a full sleep. What happens is many times we play with that schedule, or a disorder is going to affect that schedule just because it's part of the constellation of symptoms. So light, in our own circadian rhythm, we have different brain components that are going to help to maintain that schedule. And light and darkness is one of them. So there's a reason why we sleep at night. When it's dark, your brain gets a signal that says it's time to sleep. When there's light, your brain gets a signal that says it's time to get up. There are other components in the sleep cycle. So there's melatonin, which is a supplement that is produced by your brain and kind of tells your brain when it's time to sleep. So peaks around the time it's time to sleep, and then has a lower level during daytime. So we're just combining all this in order to improve not only the sleep cycle. We don't necessarily have an answer of how we're improving depression. So many times we get asked, so how does this work? And we have to just be aware that we're just ignorant of how does this work. We don't really know what the mechanism is in the brain to help depression, to decrease the suicidal thoughts. But so it's different than the light therapy in the sense that we're addressing other issues as well at the same time, not only the light therapy.
Okay, I have a question for Christine. Can you give an example of how you would approach someone using some trauma-informed care processes?
Sure. I mean, I can tell you how I do it. With all my interactions with patients, I usually start with something that's pretty light. It's not very intensive. I don't go at it with why are you here? What's going on? I usually try to relate first to, them. What are they experiencing? Because usually the people we see are at, their worst. This is their worst moment probably, that they're hospitalized and they're here and they don't want to be here. So I really do a lot of empathy with them and realize, yeah, it sucks. You're here. What are we going to do? What would you like to see happen? Really empowering them to be a part of this decision. Because a lot of times, they're kids that I work with mostly, and they don't feel like they have a lot of power. They don't feel like they have a lot of choice in if I have to go to therapy, if I have to take medications, if I have to do residential treatment after this. So if we can get them start talking and thinking about, well, if I did have a choice, what would it be? And so then I usually try to reassure them, okay, so when we have a family meeting, I'm going to talk about that. I'm going to tell your mom you don't want this or that, or you don't really like that therapist, or this isn't working for you, and kind of advocate for them and just build that relationship. And if they're having a bad day, it's, it's not go to your room, it's not stop it. It's very much a, what's going on? Like, let's take a walk, or let's go calm down, let's listen to some music, let's go to my office, what can I do? And that's how I try to that's how I try to approach trauma-informed care.
So it sounds like you're not just dealing with the kind of the outward behavior, but a little bit about some background information, how you got here, and kind of not trying to re-traumatize and put people on the defensive.
That's a big part of trauma-informed care, is not re-traumatizing the patient. It's being aware of trauma triggers, like, were they restrained? Were they locked up? What sets them off? And being aware that, Patients might not want to be touched. Patients might not like confined spaces, that sitting in this close of proximity with somebody may be very stressful to them. And so just being aware of that there's a whole slew of things that may be setting them off and just trying to figure it out, and being very mindful of it.
There's a question about utilization of any of these, whether it's a triple chronotherapy or equine therapy, or being involved in therapy with someone who is providing trauma-informed care. Are these modalities effective for someone who does not want to be taking medicine? They refuse a pharmacological approach?
Yeah, so that's how this started actually for triple chronotherapy. We don't necessarily recommend it as an only treatment modality because we don't have any clear studies of what the long-term effect of this is. So most of the studies that were done in adults were with a limited time of follow-up. So we don't know how sustained this can be. And so we don't recommend it as an only therapy, but it can have a role in that. It's just not something that we can say, yeah, definitely you can do only this and you're gonna get better. We don't know what the lasting effect is as of now. So we're working on getting there, but it's gonna take a while to know if this is really something we can do alone. So the recommended treatments for depression include medication and therapy when it's indicated. So we wouldn't recommend it only for now.
I think trauma-informed care is a good starting block for things like that. I had the privilege of working with the kid that started the light therapy, and it was just a lot of letting him talk. It was a lot of just letting him feel empowered that he could make these decisions, that he flat out refused medication, that he wasn't going to do this and he wasn't going to do that, and just sitting with him every day. And, you know, unfortunately he was with us for a really long time, but we got to know him really well, and just spent a lot of time with him and understood where he was coming from and what his family was like and why he didn't want to do, you know, medications and what he wanted for himself. And I think over time we just saw that he made the change. It was building that connection with somebody that I think opened him to being able to take a medication eventually and do this process. And it was our staff who was very patient with him and just know that, you know, he's just going through something.
I think that's one of the interesting things about the whole protocol is there's so many hours up and hours up at night, and there is a piece of just talking, and people become a little uninhibited and really, you know, start to talk about stuff. We've seen that with a lot of patients, and it's an aspect of it that we, you know, just exploring still, you know, so.
And as far as equine-assisted psychotherapy, most people who are delivering equine-assisted psychotherapy are not psychiatrists. Most people are master's level therapists. And so more often, that modality, there probably is a split. If people are taking medications, that's done by somebody else. And the therapy is delivered by a master's level therapist. So I think as we think of it now, there are a host of diagnoses, psychiatric diagnoses, where we think that equine-assisted psychotherapy may be of benefit. I think the anxiety disorders, mood disorders, there's some data for attention deficit hyperactivity disorder. So there's a fairly broad range, and not everybody needs to be on medications, obviously, and some people will opt not to be. What the hope is that at our program is that we can combine medications and psychotherapy in one particular session to see if we can get better outcomes than if they were delivered in different settings. And so I think we don't have the information, we don't have the data to support that yet, but that's one of the hypotheses that I would have.
I do want to thank all four of you. I know you're very busy people and very busy practices. I appreciate taking time to help inform the community and to kind of advance the practice of making people's lives better. Thank you.
Thank you.